In today's MedicoApps masterclass, we will discuss about autoimmune hepatitis. Autoimmune hepatitis, a chronic inflammatory liver disease caused by an immune-mediated attack on hepatocytes, meaning the body's immune system mistakenly targets the liver cells, leading to inflammation and necrosis. The key point here is that there's no identifiable external trigger, which is why we call it idiopathic. This condition is also known by older terms like leukoid hepatitis or plasma cell hepatitis based on its histological features. Now, immunologically, it's primarily driven by T-cell mediated cytotoxicity, especially CD8 plus T cells, which attack liver-specific antigens. This is important for understanding its pathophysiology. It's not just general inflammation, but a targeted immune response. There's a clear female predominance with a female to male ratio of about 3:1, and the age distribution is bimodal, meaning two distinct peaks, one in adolescence and another in middle age. This is a high-yield epidemiological pattern. From a genetic standpoint, HLA associations are frequently asked in exams. Autoimmune hepatitis is linked to HLA-DR3 and HLA-DR4, which are also associated with other autoimmune diseases. And speaking of other autoimmune diseases, autoimmune hepatitis often coexists with them. So clinically, if you see a patient with Hashimoto's thyroiditis, celiac disease, or ulcerative colitis, and they present with elevated liver enzymes, think about autoimmune hepatitis as a possible diagnosis. It's also seen alongside membranoproliferative glomerulonephritis and Sjogren's syndrome, in particular, Zika syndrome, which presents with dry eyes and dry mouth. Now let's break down the types of autoimmune hepatitis, AIH, a very exam-relevant classification that's based primarily on the autoantibodies detected in the patient's serum. Type 1 AIH, classical autoimmune hepatitis. This is the most common type and it can affect any age group, although it's more frequently seen in young adult females. Serologically, it's positive for ANA, anti-nuclear antibody, atypical P-ANCA or X-ANCA. Note that this is not the classic C-ANCA seen in GPA. You may also find positivity for SMA, that is anti-smooth muscle antibody, and anti-SLA, that is soluble liver antigen. These antibody profiles help differentiate it from other types and also from viral hepatitis or drug-induced hepatitis. Type 2 AIH, this is less common and seen mostly in children and adolescents. The hallmark antibody here is anti-LKM1, which stands for anti-liver kidney microsomal antibody type 1. Now, this is an important exam trap. Remember, anti-LKM1 can also be seen in hepatitis C, so sometimes type 2 AIH may be misdiagnosed as hepatitis C based on serology. Always correlate with clinical picture and other markers. Type 3 AIH. This is a bit of a gray zone. It's characterized by the presence of anti-SLA antibodies, similar to what we sometimes see in type 1. Because of this overlap, some researchers group type 3 with type 1, but you should still know the name for the sake of exams. It's less common and again, may overlap clinically and serologically with type 1. Let's now look at some additional autoantibody associations which are very helpful not only for diagnosing autoimmune hepatitis, but also for differentiating it from other vasculitides and liver disorders. This is high yield for both NEAT-PG and INI set. X-ANCA, also known as atypical P-ANCA, this is commonly seen in type 1 autoimmune hepatitis. While not very specific, its presence along with ANA and SMA supports the diagnosis. P-ANCA, perinuclear ANCA. This is classically associated with microscopic polyangiitis, Churg-Strauss syndrome, now called eosinophilic granulomatosis with polyangiitis. These are small vessel vasculitides, and P-ANCA helps differentiate them from C-ANCA related diseases. C-ANCA, cytoplasmic ANCA, highly specific for Wegener's granulomatosis, now known as granulomatosis with polyangiitis, GPA. Buzzword. Look for upper respiratory plus renal involvement. Anti-LKM1, liver kidney microsomal antibody type 1. This is a hallmark of type 2 autoimmune hepatitis, mostly in children. Important to note, it may also be falsely positive in hepatitis C, leading to diagnostic confusion. Anti-LKM2. This one is much rarer and typically seen in drug-induced hepatitis. Anti-LKM3, associated with hepatitis D virus, HDV, infections. Let's now explore the etiopathogenesis of autoimmune hepatitis, which is key to understanding why this disease happens and how it behaves. Etiology and triggers. The exact cause remains unknown, but we believe it's due to a combination of genetic predisposition and environmental triggers. In genetically susceptible individuals, certain exposures can trigger a breakdown in immune tolerance, leading to an autoimmune response. Possible triggers include viral infections such as hepatitis A, B, C, and Epstein-Barr virus, EBV. These may act as initial immune stimulants that confuse the immune system into attacking self-tissues. Drugs, especially minocycline and nitrofurantoin. These are well known to cause drug-induced liver injury, but in some cases, they may unmask or initiate autoimmune hepatitis. Environmental toxins, though less well-defined, certain chemicals may also play a role in initiating the immune reaction. So the take-home message is, AIH is not inherited in a Mendelian way, but requires a trigger in someone who is genetically susceptible. Pathogenesis. The core problem is a loss of immune tolerance. In healthy individuals, immune cells are trained not to attack self-tissues. But in autoimmune hepatitis, this tolerance is lost and autoreactive T cells get activated. CD8 plus T cells, also called cytotoxic T cells, play a central role by directly attacking hepatocytes, leading to hepatocellular inflammation and necrosis. B cells contribute by producing autoantibodies like ANA, SMA, and anti-LKM, which further amplify the immune response and sustain liver inflammation. This dual attack, cellular, T cells, and humoral, B cells/antibodies, is what causes the chronic liver damage seen in autoimmune hepatitis. Let's now look at the clinical presentation of these patients. We begin with the fact that the disease is initially asymptomatic. This is important because many cases are not picked up clinically, but rather incidentally during routine liver function tests. So patients may have significant liver injury without any obvious complaints early on. Patients may later present with non-specific symptoms such as fatigue, malaise, anorexia, weight loss, and arthralgia. Notice that these are very vague features and can mimic many other conditions. That's why early liver disease often gets missed unless there's a high index of suspicion. The most striking clinical sign is jaundice, but here it tends to be waxing and waning. This fluctuation is a classic description and often seen in chronic liver conditions. For exams, always remember that intermittent jaundice should raise suspicion of chronic hepatitis. In females, amenorrhea may also occur. This reflects the hormonal disturbances associated with chronic liver dysfunction, since the liver is involved in estrogen metabolism. Another feature is right upper quadrant abdominal pain. This discomfort is due to stretching of the liver capsule or associated inflammation. As the disease progresses, features of chronic liver disease begin to appear. These include stigmata like spider angiomas, Palmer erythema, gynecomastia, and ascites. This is a key transition point from early to advanced disease. Finally, the most important long-term complication is the increased incidence of hepatocellular carcinoma, HCC. This is a classic exam question. Chronic liver disease is one of the strongest risk factors for HCC, and surveillance is critical in such patients. Let's go through the workup and diagnosis step by step. First, notice the liver enzymes. In autoimmune hepatitis, ALT and AST are markedly elevated, often more than 10 times the normal level. This degree of elevation is very important and is frequently asked in exams. Next, look at the serum proteins. You'll find elevated IgG and gamma globulins because of impaired catabolism. This helps differentiate it from conditions like multiple myeloma, where albumin remains normal. Here, albumin is usually low, and prothrombin time is prolonged, reflecting impaired synthetic function of the liver. Moving on to autoantibodies. The commonly seen ones are ANA, SMA, anti-SLA, and anti-LKM1. The presence of these autoantibodies is a hallmark diagnostic clue and a favorite exam question. Another crucial point, viral serologies must be negative. This is essential because autoimmune hepatitis is a diagnosis of exclusion. We first rule out viral hepatitis. Now, let's discuss the liver biopsy findings. The characteristic feature is interface hepatitis, also called piecemeal necrosis. You'll also see lymphoplasmacytic infiltrates, which are very suggestive, and sometimes rosette formation, which indicates hepatocyte regeneration. This histological feature is a classic exam buzzword. Finally, always remember this is a diagnosis of exclusion. That means we must rule out other causes such as viral hepatitis, alcohol related damage, drug induced hepatitis, and genetic disorders like alpha 1 antitrypsin deficiency, Wilson's disease, and Menkes disease. Moving forward, let's now discuss the treatment and prognosis of autoimmune hepatitis. The main goal of treatment is to induce remission, maintain it, and most importantly, prevent progression to cirrhosis and liver failure. The first-line therapy is a combination of prednisone and azathioprine. These drugs help suppress the immune-mediated liver damage. This combination is a very important exam point. Once remission is achieved, patients are shifted to maintenance therapy. This usually involves low-dose corticosteroids or sometimes azathioprine monotherapy to keep the disease under control long-term. If the patient is non-responsive or intolerant to first-line drugs, we move to alternatives such as mycophenolate mofetil, cyclosporin, or tacrolimus. These are used in refractory cases. In late stages, when there is decompensated cirrhosis and the child Pew score rises above 7 or 8, the definitive treatment becomes orthotopic liver transplantation. Now coming to the prognosis. If autoimmune hepatitis is diagnosed early and treated promptly, the outcome is excellent. However, if left untreated, the mortality rate can reach as high as 40% within 6 months. A very striking exam fact. After transplantation, recurrence is rare, but it is still possible.